Okay, so hi everyone. Today we're going to be talking about N95 respirators versus medical masks for preventing influenza among healthcare personnel. So just a little background about the flu. So influenza is a contagious respiratory illness caused by the influenza virus that infects the nose, throat, and the lungs. So it can cause mild or severe illness and sometimes can lead to death. So sometimes individuals like older people or younger children and people with certain health conditions have weakened immune systems and therefore have a higher risk of flu complications. So the two main types of influenza are type A and type B, and they are regularly spread through humans, and these are responsible for the seasonal flu epidemics every year. So flu viruses are spread mainly by tiny droplets made by people with the flu who cough or sneeze or talk. And then these droplets can land on the mouths of other people or the noses of other people, or even nearby surfaces, and they can be inhaled through the lungs. And then people with the flu are most contagious in the first 3 to 4 days after their illness begins. So most healthy adults may be able to infect others beginning 1 day before symptoms develop, and they can continue to infect others up to 5 to 7 days after becoming sick. And then, like I said before, children and some people with weakened immune systems may even pass the virus longer than 7 days. And then symptoms can begin around 2 days after the virus enters the body. So that means that you may be sick and pass the flu on to someone else before you even know that you are sick. So another problem is that some people are infected who are also asymptomatic. So that can spread the disease without even knowing it.
So just an introduction for this article. The target population for this was frontline workers and medical workers who work in close contact with people who may be infected. So healthcare personnel can have routine exposure to viral respiratory illnesses, given that they work with people who may have this infection. But something that's of concern is that many have incomplete adherence to prevention strategies. And they mentioned that it was between 10 and 84%, which is a big range. And that can show that a lot of leeway can happen when you're dealing with certain prevention strategies. So before I go any deeper, I wanted to ask, what do you guys think are some potential prevention strategies for like transmission of influenza? It can be anything.
Someone said hand washing in the chat.
Right, yeah. That's one that I had. It's like sanitation is a big one. So it can transfer from surfaces, along with like masking, since we mentioned that. And then also just like testing and social distancing were some other ones that I thought of. So for this study, they were looking to see that prior studies had shown that the N95 respirators may have better chances at reducing aerosol exposure compared to medical masks. But there had never been any comparative effectiveness trials to showing any conclusive results for this trend. So what do you all think could be some potential consequences, given that there are two different types of maskings and they haven't shown any conclusive effectiveness differences for the difference in the adherence? Like, could that prevention strategy be different in different healthcare settings with these different types of maskings? And I can't see the chat, Morgan. So if somebody said anything, just let me know.
Yeah, no one said anything about this question, but your prior question, someone said covering your mouth when sneezing.
Yeah, so very similar stuff. And then also through this article, as I said before, they haven't shown any conclusive like differences between the different masking methods, even though they do have different purposes and different, prevention setups. So N95s, as you know, are much more close to the face and they don't allow any lateral transmission of air or aerosols, whereas medical masks are a little less tight to the face, but they do both prevent some aerosol exposure. So the study aimed to deal with that. So the main objective that they mentioned was that they were going to compare the effectiveness of N95 respirators versus medical masks worn by healthcare personnel in clinical practice. And they wanted to focus on those who had high exposure in outpatient settings. And they had it from very different geographically diverse regions. So their null hypothesis that they tested was that incidence of laboratory confirmed influenza and other influenza-like illnesses would not show a difference between the different treatment groups of N95 mask or surgical mask. So for the eligibility criteria for this trial design, they randomly chose clusters, and the clusters were different outpatient clinics in the United States. And within each cluster, they were given a set treatment of either N95 or medical masks. And everyone in that cluster received the same treatment. So all medical personnel had to be at least 18 years of age, and they had to be fully employed at the healthcare system they were at. They also did have to self-identify as practicing social distancing when they had patients who may have been showing symptoms. So that was something they had to like kind of self-report, which is a little tip that I wanted to bring up. And they also had to pass a fit testing for the respirators, which was important because if they couldn't properly wear the mask, then that could alter how the exposure may have affected them. And they also maintained a diary of their symptoms and their signs, their vaccination status, and their exposure throughout the extent of the trial. So I mentioned that they used different clusters of outpatient clinics. Why do you think that they used a cluster trial design for this study?
So it's not practical necessarily to randomize at the patient level because adjacent patients randomized to different interventions will start questioning why one patient got a bigger, denser looking mask than the other. And also just from an allocation standpoint, it might be practical just to hand out masks, the same mask at different clinics.
That's a good point. Very good point. Anybody else?
In the chat, there's something, it says improve adherence, minimize influence between individuals.
Yeah, same kind of point. And that was kind of what I brought up, is like the crossover and contamination between treatments that could bias something away from what the true effect was. So that was important to have it uniform at each cluster and to have that be like the same. And then also some exclusion criteria that I mentioned were that they could not have any of their systemic diseases, which could impact, how their symptoms may present when they were infected maybe or exposed to it. They couldn't have any facial hair or adornments that could, cause them to fail the fit test, which could affect how their masks fit. And they had to work at least 75% full-time at their outpatient clinic or their healthcare setting, because that would allow for adequate exposure and uniform exposure across participants. And they had to be someone who regularly, used PPE. If they didn't use it regularly, that could affect how they were exposed as well. And there was one other little thing from this exclusion criteria that I wanted to mention. In the article, they talked about how participants were self-identifying for race and sex using fixed categories. And I wanted to mention that because I wanted to get y'all's opinion. Do you all believe that these two variables could be potential effect measure modifiers for exposure and masks fitting and all that stuff? Because their rationale in the paper was that different anatomical features in terms of the facial structure could affect how the mask could fit. And using these two different variables, that can impact exposure. So do you feel like these two variables should be stratified for in the analysis?
And remember that the unit of randomization here is a cluster.
Taking what Teresa said into account, that's individual data, and it might be really hard to account for during the analysis. But also, I'm wondering how big the effect is going to be, because they had all the fit test. So if they wouldn't fit the mask because small face or big face or something, they would be excluded anyway. So I'm not sure if there would be an effect at all.
That's a good point. Yeah, and one other thing that we mentioned when we were going over this part was basically that race and sex, or at least for race, it's not a concrete, fixed, definition across the board. You could have someone who thinks they're something which are not. And if you put them in a certain category, you're fixing for a variable that may not be uniform in terms of like what they self-identify as. So that really would kind of make a large gray area in terms of like what the actual effects could be. So this variable would be hard to adjust for.
Okay, so getting into the trial design. So this was a cluster randomized, multi-center pragmatic effectiveness trial. So pragmatic effectiveness trials are becoming more important for medical evidence. So because efficacy studies may overestimate effectiveness and true adherence. So this study was conducted between September 2011 and May 2015, and the final follow-up was June 28th, 2016. So it compared the effect of N95 respirators and medical masks, which were used as recommended to prevent seasonal influenza and other viral respiratory infections and illnesses among healthcare professionals. The investigators were blinded to the randomization until the end of the study and the analysis, and independent data and safety monitoring board assessed the data. So this study assessed and compared the effectiveness of respiratory protective equipment among healthcare professionals and in the outpatient setting. So these outpatient settings included urgent care facilities, emergency departments, dental clinics, and adult and pediatric clinics, and primary care facilities. You can go to the next slide. So with that in mind, why do you think they chose an outpatient setting for this clinical trial?
To maybe get a very realistic population, so not only very sick influenza people who are hospitalized, but also like the milder forms or even asymptomatic patients who are just infecting the healthcare professionals, so to get a broad and realistic population.
Yep, that makes a lot of sense. Any other points? Oh, Jasmine said, would it be because there are more flu exposure in outpatient settings? Yes, that's a huge point, actually. So the study, I said the outpatient setting was chosen because it was the front line in the event of the influenza epidemic. So yes, that makes sense. And then there's also other ethical considerations as well. So inpatient is usually more strict. So randomizing an outpatient setting, you have less ethical issues with that. You can move on. I don't know if anyone has anything else to add.
One small comment. It is possible to randomize in a pragmatic trial in an inpatient setting by hospital floor or intensive care unit. That's been done in nursing homes and other sort of inpatient indwelling settings before.
Okay, awesome. Didn't know that. Okay, continuing on. So for the cluster randomized design, there were 7 sites, and at each of these 7 sites, there were about 20 to 25 outpatient clinics. So about 20 participants were at each clinic, and the cluster randomized design was utilized so that each group or cluster had about 20 people randomized to wear the same device, whether that was the medical masks or the N95 respirators. And this was per 2007 CDC guidelines for the medical masks and 2009 guidelines for the N95s. And they wore these devices for about 12 weeks while they were working at their study site location. So the intervention period, each flu season for the study was up to 12 weeks per flu season. And during this time, participants were to provide an upper respiratory specimen, and while also adhering to mask use and hygiene. So the way that adherence was measured was through trained research assistants who would observe the clinics to determine adherence to the correct facial protective equipment use and adherence to the correct number of mask changes. So more specifically, participants were instructed to put on a new respirator or a mask each time they came into contact with a person who was within 6 feet or a patient that was suspected or confirmed respiratory infection. And then hand hygiene was also observed. And then these trained assistants that came unannounced. So there were unannounced observations that occurred in each clinic throughout the intervention period. There were also 3 different surveys, and these included a baseline survey, a pre-study survey, and a post-study survey. So the baseline survey pretty much collected contact and demographic info, vaccination status, smoking status, history of systemic disease, and medication use. And then the pre-study and post-study survey addressed attitudes and beliefs about personal protective equipment and whether that changed, whether their opinions and attitudes changed after this study was conducted. And then this is just kind of an overview of everything that kind of occurred. So they started with about 480 clusters, but they excluded 99 because they didn't meet either the inclusion criteria or they declined to participate. And then from this, they were left with about 380 randomized clusters to either the N95 group, which had about 1,990 participants, or the medical mask group, which had about 2,060 participants. So from the 89, 189 and 191 clusters in both groups, 2 clusters were discontinued because they were too small, because they only had 1 person per cluster. So having too small of a cluster with just 1 person can impact the results of the study, because how can a 1 person cluster carry the same weight as a cluster that has about 20 people? It doesn't really work. So they excluded these clusters, and then they were left with 187 clusters in the N95 group and 189 clusters in the medical mask group. So with that being said, I don't know if I have a question on the next slide. Do I have another? Oh, nope, go back. I have a question that follows up with this. So why would we want to use matched clusters?
So the two could be better compared because they're more similar.
Yeah, that makes sense. Mm-hmm. Anyone else? Yeah, someone said comparable.
Reduce confounding by differential sort of allocation across certain medical centers. So if Hopkins had more clusters and randomized to the N95, for example, that would be a problem.
Yeah, that's a good point. In the chat, increased statistical power. Yep, that's a huge one. Yeah, so it gives you more precise estimates and you want to minimize the variance here.
So in more detail about just the follow-up, Morgan mentioned that each intervention period was 12 weeks and a 12-week period was like categorized as a respiratory season. So they had 4 different flu seasons, they were consecutive. Each was 12 weeks. And during those 12-week periods, they did 2 random swab collections. And these swab collections were from the anterior nares and oropharynx area to culture and then get tests for the viral particles. And they tested for influenza and also other influenza-like illnesses. So they had 2 random swabs per 12-week period, as well as any symptomatic swabs. And by that, I meant someone who was a person who was exposed and they had symptoms and they self-reported these symptoms. Within 24 hours, they got a test again to see if they also had the illness from these tests. And like Morgan mentioned, they had different levels of strategies for ensuring that the participants ensured that they had adherence. So they were reminded about this adherence through multiple different ways, through signage at their different facilities. They also had it through email and also through the study personnel telling them regularly. They had daily adherence reporting, which they did after every single day at their jobs. And they reported at a scale of always, sometimes, never, or did not recall about how often and how much they wore their masks. And like Morgan mentioned, they had the random inconspicuous visits to their study sites to where they wouldn't know, when or how they were being monitored. And that gave an extra level of monitoring and ensuring that the adherence was taking place. So based off of these different levels of, monitoring and measuring the adherence of masking, what are some potential benefits or drawbacks for having these different strategies in place?
One benefit of having different strategies is that even though, for example, an email can be ignored, if a study personnel is coming to me and reminding me, it's less likely that I can totally ignore their recommendation.
Right, yeah. Because there's different, mediums of trying to reach out to people. So that's a good way to keep in touch. Anyone else?
Will it also help to verify the adherence, like a self-report? I think if you have a monitor, like a random visitation monitor, maybe can help to verify the self-report result.
Right, yeah, because you could say you always wore your mask, but if someone, is monitoring you and you just tend to forget or overestimate how much you're wearing it, that can affect, the exposure you may have to what it truly is.
One drawback is maybe that it gets annoying if you have so many reminders and so on. So maybe at some point the participant gets angry and don't adhere because they are fed up with reminders.
Yeah, that's definitely an option.
There's a comment in the chat that says could be a burden on the participant.
Yeah, definitely. Getting barraged with all these things about masking over and over again. When you're already in a clinic, that could be a lot. Some other ones that I wanted to mention, could there be potential differences in reporting of symptoms between people who are wearing different masking, treatments? I don't think off the top of my head, I don't think there could be, but I wanted to get you guys' opinions on what you think. There could be any differences between these two groups.
It's just a guess, but maybe if you're believing that, for example, the N95 mask is better, I might not report the symptoms because I believe it's not influenza, but that's just a guess.
That's a good point. I didn't think about that, but definitely, just based off other lab studies that have maybe shown that N95s could protect you better, for sure.
And what are we concerned about with differential reporting in this particular study?
Well, for differential reporting, you're thinking about just like that could affect how much you think they're exposed overall, which could impact, whether there actually is a difference in the treatment.
And if there is differential reporting, then we're going to your next question about the random swaps or not, because if everybody is reporting their symptoms very well, then maybe 2 asymptomatic swaps are enough. But if there's differential reporting bias, then there should be more swaps.
That's a very good point. And I guess just segueing in, so for the second question, anybody else have anything to think about for just only 2 random swabs in a whole 12 weeks of the intervention period? Do you think that's enough, or do you think there should be more or less, or is just the right amount?
I thought it was not enough. I don't quite have the mathematical sort of terminology to articulate this, but it just seems like an imprecise measurement for an otherwise objective outcome. 1 every 6 weeks on average. that's a long time to develop and recover from a respiratory illness. So I'm just concerned about a lot of noise, a lot of imprecision in their estimates of infection.
Yeah, I agree.
Cool, but if you would believe that, for example, every symptomatic one is reporting, so if I'm symptomatic, I should have more than 2 swabs. That's the thing. I'm just not sure how many asymptomatic people there are around, because if I'm getting the flu, so if I got I think twice in my life flu, and I was symptomatic, so I don't know the proportion of asymptomatic healthy people.
Yes, although it's certainly possible to have asymptomatic respiratory infection, and then spread it to other people, as we know with.
Yeah, totally. I'm totally biased by my personal experience, but I have no data to confirm or not. But just saying, if you're symptomatic and you're reporting it, you should have more than 2 swabs.
I also wonder how accurate these swab tests can be. I don't know if anyone knows that.
I think it's the gold standard from the CDC book for now, PCR swabs. But there, I'm not 100% sure.
Thanks. That's maybe why they were confident that 2 random swab tests were enough.
Okay. And then just following up with that, I was waiting to say PCR, but that was what I was going to say for the next slide. So the primary outcome was they were using a PCR, like the reverse transcriptase test for influenza. And that was, the symptomatic test if they were showing symptoms or if they were asymptomatic through the random test. So they had multiple ways to show the primary outcome of the positive test from influenza. And another one they mentioned was that they used the blood sample for the elevated antibodies for influenza in their blood samples. So this was pre and post intervention. That could be both ways. And then some secondary outcomes they mentioned were just signs and symptoms for influenza or these illnesses. So it was a mixture of both, for not just influenza, but other ones that are similar to it, since they kind of overlap in their symptoms. But both of those were seen as like secondary outcomes. And just another question that I wanted to mention, because they said very specifically in the outcomes that the test had to be within 7 days of symptoms. So why do you all think that 7 days was like the cutoff for like a test to be confirmed following symptoms?
I think for most of viral infections, by 7 days, the viral loads will be significantly reduced. They're probably less likely to be detectable. But for individuals actually have a severe disease, the 7 days, even beyond, are probably still detectable.
That's a good point. Anybody else? No, I'm just gonna move on.
Okay, so this just kind of goes over like an overview of the study. So the question at hand was, is the use of N95 respirators or medical masks more effective in preventing influenza infection among outpatient healthcare professionals and a close contact with patients with suspected respiratory illness? So the study looked at healthcare personnel who were in settings with high prevalence acute respiratory illness at 7 U.S. medical centers. So healthcare personnel were randomized into either the medical mask group or the N95s and were to wear them when they were within 6 feet of patients with respiratory illness. This cluster randomized clinical trial found that as worn by healthcare personnel, the N95 respirators were no more effective than the medical masks as measured by the rate of the laboratory confirmed influenza events. So So with that being said, do you think that this study was designed to succeed? I mean, obviously it wasn't designed to fail, but I guess what I'm getting at a hint is, I guess I would be that they were already looking at healthcare workers who were likely vaccinated. So do you think that has an impact on how this trial succeeded or failed?
So one of the issues is, what is the effectiveness of the vaccine, and how does it influence the number of potential events? So if the vaccine were 100% effective, then yeah, this would be very difficult. If the vaccine is 50% effective, all it does is reduce the number of events and inflate your sample size.
That's a very good point. I agree.
I think if they have done the study in another population, like in the general population, the results might be different because the healthcare workers, they are highly aware of self-hygiene, how to protect themselves from infectious disease. So this may kind of dilute the effectiveness of this facial masks.
Yeah, it's another great point. They have more knowledge, considering they are healthcare professionals who do this for a living.
And in their introduction, they also said a health worker are more likely to not adhere to mask wearing, right? And I mean, in their case, the adherence is pretty good.
Yeah, I guess it just, it might depend. In this case, it seems like they took the adherence pretty seriously because they had the research assistants coming in unannounced. So I guess it just kind of depends.
And they excluded all the participants who didn't tolerate the mask.
Mm-hmm.
Because this would be potential non-adherer.
Right. Okay, we can move on. So this just shows the different demographic characteristics and the risk factors, site enrollment of the healthcare personnel. So across the characteristics shown here, we have clinic type, site, occupation, and occupational risk. And there's not really much of a difference between the N95 group and the medical mask group, as their numbers are very comparable across each category. So there isn't one particular cluster that's driving any differences here. They all pretty much are saying that there's no difference between the two types of masks. So before I get into the results, they mention intention to treat and per protocol. So randomized controlled trials usually have two major complications, and these are noncompliance and missing outcomes. So a solution to this problem is the statistical concept of intention to treat analysis. And this includes every subject who is randomized according to the randomized treatment assignment. So it ignores noncompliance, protocol deviations, withdrawal, and anything that happens after randomization. So in an intention to treat analysis, the estimate of treatment effect is generally conservative, and a better function of the intention to treat approach is possible if complete outcome data is available for all the randomized participants. And then for per protocol population, this is defined as a subset of the intention to treat population who completed the study without any major protocol violations. So getting into the results, so here we can see that the confidence interval crosses 1. So this indicates that there is not a statistically significant difference between the use of the N95 respirators and the medical masks. So therefore, the N95s were no more effective than the medical masks as measured by the rate of the lab confirmed flu events. With that in mind, though, what are the reasons that the authors identified for not seeing a difference between the masks? So in other words, what are the limitations?
It's possible that they didn't detect all the infections, or the self-reporting is not accurate.
Yep, self-reporting. That's a very good point.
Yeah, I have a question here about the analysis, and I didn't read the supplement, and perhaps the answer was in the supplement, but if they matched clusters, then the analysis should be considering the difference between matched clusters and not forgetting about the matching when the analysis is done, as we do in case control studies. And I couldn't find that in the main paper. The answer might be in the supplement. Does anybody know the answer to that?
Yeah, Dr. Hurst and I had checked. They did not do that, so I was also concerned about that.
Yeah, that's, I don't know. I mean, the reason I raise it now is Morgan has asked, why is it they didn't find a difference? Well, they might have had a more sensitive analysis if they had done it that way. Probably not, considering these numbers.
And this, I mean, it goes back to Morgan's first question about whether they were set up to fail. There were certainly design decisions that might have contributed to the outcome they saw.
Any other thoughts or limitations that you guys can think of?
You know, if you go back to the numbers for a second, it looks like although there's no difference because the hazard ratio, the 95% confidence intervals cross 1, the actual magnitude is in the wrong direction based upon the a priori hypothesis. So, you know, any and all analytic deficiencies probably aren't going to make it go in the right direction. The only thing which I would think is that the reporting of symptoms, the individuals wearing the masks were not, they knew what they were getting. So they were both masked and unmasked, as it were. And therefore, if you have an a priori bias as a healthcare professional, your reporting of your symptoms may be differential based upon the absence of masking as to which mask.
Yeah, that's a very good point. I think a few other things to mention that the authors stated in the article is that the PCR testing may have missed participants who were infected but were asymptomatic. So unrecognized infections may have increased the probability of finding no difference between interventions. I think somebody did mention the self-reporting. So self-reporting of symptoms in their daily diaries likely could underestimate illnesses who work for, I guess, healthcare professionals who work while they're ill. Another important thing to mention is that participants are not instructed to wear their protective devices outside of the workplace. So this could have biased results toward finding no difference between the groups. This is unknown, but it's just things to think about.
Do you think it might also contribute to that because maybe they are really good at adhering to hand washing and the distancing? And if the N95 is very good with the aerosol droplet, and if they keep their distancing, and that might be less really useful in the setting?
Yeah, definitely.
So I feel like we touched on the first one pretty heavily, just like on what could be improved upon and what may have been a shortcoming of the study. But I feel like with the second question, and versus why it's relevant now, because I feel like it's pretty obvious why masking is relevant right now. I wanted to say more of like, what do you all think could be taken from the study for, day-to-day life of people who are dealing with, masking adherence right now in healthcare settings, and just like moving forward, what they could take from these results to better take care of patients who they might be infecting or may be exposed to, influenza, COVID, any kind of aerosol transmissions that could happen day to day.
Well, let me ask this. I have a KN95 mask. Can I learn anything from this?
Is that a type of N95 mask? Because that was another limitation, because you can't apply a general, I guess, statement about like the type of mask, because there's different variations of it. So yeah.
In 95, it's used in Korea and in Japan, and it's sold in the United States. But no, that's just it. I don't expect anyone to answer the question. I guess I'm asking, what could I learn from this if I have a different kind of mask?
I think there's some merit to the adherence strategies that they employed throughout the trial as well. We could potentially learn something there, because the rate of adherence we saw in the trial was greater than what they had expected.
Yeah, that's a good point.
All right, if there's nothing else, we can write up on 1 o'clock. So I wanted to end it right there, but thank you all for listening and providing great feedback and being attentive.
Yes, thank you guys so much.
Thank you both.
I have a question. I don't know. So is it really, it would be, I would think, unethical to have a group that not wear a mask, right? Is that something already sort of attested? Wear a mask is definitely better than not wear a mask. I mean, I wouldn't think that the answer would be no, but just thinking it would be a control, but we can't do.
I agree. I think the ethical logistics of conducting that trial might be difficult.